My name is Lauren Broshak. I am one of the therapists here at Life with Cancer, and I'm so excited to be here with you to have the second session of our men's sexual health series. Before we get started, I'm going to share a little bit about Life with Cancer. First, we want to thank CACFI and the CDC for their grant and support of this program. We're incredibly grateful. Life with Cancer is part of Inova Cancer, providing education and psychosocial support to all individuals impacted by cancer, from diagnosis to survivorship, and through evidence-based holistic care at no cost. Our mission is to enhance the quality of life of those affected by cancer by providing evidence-based education, support, and wellness programs. We offer several group programs such as support groups, educational programs, mindfulness programs, fitness programs, and more. We also offer additional sexual health programming, such as our men's sexual health support group, Sex and Cancer for Men. We do want to make a quick note that the information presented today is for informational and educational purposes only, should not be treated as medical advice. During this session, we request that you submit your questions through the Q&A function, and we will get to questions at the end of the presentation today. I am pleased to turn it over to Dr. Inga Rosner to introduce our guest speaker and moderate today's session. Dr. Rosner is a board-certified urological oncologist and has been with Inova since 2020 and is a wealth of experience and knowledge in sexual health and cancer. We're so glad to have you here, Dr. Rosner. Feel free to take it away.
Okay, well, good evening, everyone. And first, I want to say thank you to Lauren and to Life with Cancer. So Life with Cancer is an incredible resource for our patients here at Inova. And I really love partnering with them and participating in things like this, and really just appreciate all the resources available to our patients with cancer. And it's my pleasure to also introduce Rachel Rubin. Rachel is a colleague from the DMV area, a urologist. She's nationally recognized urologist and sexual medicine specialist. She's an assistant clinical professor of urology at Georgetown University. And she actually owns her own private practice in the Washington, D.C. area, and that practice is expanding. She's one of only a handful of physicians fellowship trained in male and female sexual medicine. She's a clinician, researcher, vocal educator in the field of sexual medicine. She's very passionate about her work, and it is a great pleasure to have her here with us this evening. And she's been featured in the New York Times and PBS as well as NPR. So Rachel, it's a pleasure having you, and we'll turn it over to you.
Such an honor to be here. When I say vocal educator, it's because I'm very, very loud, and I'm not shy about it. I'm not shy about being very, very loud. So I'm going to share my screen with everybody and get set up here. Let's see if I can do this right after how many years of pandemic. Lauren, give me a thumbs up if you see the screen the right way. Okay, fabulous. You know, how long has to go by? I will try to keep an eye on the chat box if anyone has any major questions, but I also will try to really make it so that you can ask questions at the end. I promise not to talk too long, although I'm never very good at that because I have a lot to say. So I have prostate cancer there, but that's my mistake. I'm just going to talk in general cancer and sexual health. I would love for all of you to either follow me on social media or go to my website and sign up for my newsletter, not because I want more followers, but because I want you to feel not alone. And I want you to learn things and know that there are people out there who care deeply about the medicine behind sexual health and pleasure and quality of life. So for anyone who's on this webinar, the website is rachelrubinmd.com. That's a good, and my social media is Dr. Rachel Rubin. It's been really fun on social media to get really loud and really get education and good evidence-based education really spread across the world, which is really incredible to do. So if you're on this webinar, you probably are affected by cancer or have a family member who's affected by cancer, somebody you love or you care about is affected by cancer. And there's a lot of biology that goes into that, right? There's a lot of biology that happens. And then there's a lot of psychosocial and badness that happens with a cancer diagnosis. And sexual medicine has a lot to do with sort of the biopsychosocial interactions. And that's why I love it. It is so complex, right? There are body parts. There's often two people's body parts involved. There is emotion involved. There is conflict involved. There is interaction, social interactions involved. It is so deliciously rich with complexity and the human condition. And that's why I am literally obsessed with what I do. And the problem is it's so bad out there. It's so bad out there because the idea that a 10-minute doctor's visit once a year is adequate health care for you as a human being who's lived a lot of years it's just wild. It blows my mind. And so I try to do things differently. And I do a lot of yelling and educating and screaming because I believe when you all understand your bodies and how they work, you make good decisions for yourself, right? We love shared decision making, this idea that you are able and capable of making good decisions for your body. But the problem is we don't often give you all the information. If you're anything like me, this is how I learned sex ed. Legitimately, I remember the male gym teacher and I remember the middle school class. And the only thing I remember from that class was the word smegma, which I won't tell you what that means, but it's kind of funny for a number of reasons because I ultimately became a urologist, a penis doctor, and I actually do research in female clitoris smegma things. Again, we don't have to talk about it right now, but it's very interesting. But y'all, like, if you were even lucky enough to get sex ed, this is probably how you got it. And so your family probably wasn't much better because not only are we all often raised on private parts, but it's not always comfortable to talk about private parts with your own family members. So if you're not getting good knowledge from your family and you're not getting good knowledge in middle school and you go to the doctor for 10 minutes once a year, what are we left with? What are we left with when it comes to sexual health? And you got to have jokes because if you don't have jokes as a urologist, you're not doing a very good job. You got to be funny when you're a urologist. But what are we doing to help people? Now, I see all genders in my clinic, and we often, treat these private parts like we're mechanics under a hood, right? We want to keep you modest. We don't want you to see down there whether you have female genitals, male, whatever your genitals look like, right? We're kind of keep you away from your own genitals. And so what we lack is comprehensive sex education. We lack we lack information of really letting people make good decisions, empowering people to understand pleasure and quality and safety and fun and good body image, great sex. And it's really, we miss out on all that biopsychosocial ability to really maximize our quality of life. Because remember, the point of sex right now is fun. Many of you are not trying to have babies anymore. And even people who are trying to have babies, it's a small percentage of your life where you're trying for this reproductive thing. And so sex is really supposed to be about play and fun and joy and happiness and intimacy. And so much of that is missed and hurting because of these biopsychosocial issues that your doctor often never even asks you about, let alone knows what to do about if you do have issues. But it matters. I always say nobody comes to my clinic with a little problem. And again, the idea that we can do this as doctors in 10 minutes and really, really get to know you, get to know your story, get to know all the details. It's kind of a joke if you ask me. And so it matters, right? So these things matter to our patients, it matters to their partners. But I always joke, I don't do amazing cancer surgeries like Dr. Rosner, by the way, is absolutely incredible. Just amazing cancer surgeon, does giant intricate surgeries and truly saves lives all the time. I don't do those things. I'm amazed and in awe of her every day. I do 4 things, right? I deal with issues of desire, arousal, orgasm, and pain. And so I only do 4 things, but they're these things which are affected with cancer issues. It really, truly, all of them can be affected with any kind of cancer that you have. And it really is important to have a place and a team of people potentially who can really look at you and really try to understand what's going on with your body and to say, how can we maximize your quality of life and your sexual health? If it's important to you, it should be important to your care team. And I always joke, listen, I think of myself as a sex detective. It's a little bit silly, I know. See, I can't see any of you laughing because there's no cameras here, but I do. I think of myself as a sex detective, and I really try to figure out complex puzzles. People come from all over to see us in our clinic to really try to figure out complex issues, whether it's low libido or pain with orgasm or delayed orgasm or horrific pelvic pain that can't be explained by the 27 doctors you've seen before me. And so it's a puzzle. Like I love it. I love dealing with these complex issues because it really, really is a puzzle. And I always tell my patients is that nobody gets better just with me and my magic wand. They don't. They get better because they often work in a team. And I'm going to go over a little bit of what that team might look like. You know, the idea that your cancer surgeon is the only clinician that you see for your post-cancer care, that's what I try to get people to realize is that you need a team, that like anyone, you deserve a pit crew. You deserve several people working with you to care about you, to genuinely listen and to really try to work with your personal story to sort of maximize your outcomes, right? Investing in yourself and it is always the right answer. It's always the right answer. And we don't do it enough, right? We don't do enough investment in ourselves, in our own health, right? We don't spend enough time going to the doctor or going to mental health care or doing musculoskeletal pelvic or physical therapy exercises, but we really all should do a lot more of it. So when people come to see me with sexual problems, whether they have cancer or not, right, we really try to help them maximize their quality of life. And we often work with a team. So whether it's somebody like myself who does the medicine and the biology and really explains the physiology, how the body is working, we deal a lot with hormones and medicines and things like that. There's also often a musculoskeletal component to sexual health care. You don't think about it too much, but orgasm is just a reflex, right? The pelvis, which the penis is just a muscle, and that muscle cannot function very well. And the muscles that surround the penis can be affected. That can affect your erections, your orgasm. So we do a lot of muscular. If you have sciatica of your leg, right? It's a leg pain, but it's a back problem. You can get sciatica of the penis or of the vulva, and no one really is looking at this. It's really a problem, and it's not uncommon actually. And we also deal with a lot of mental health care, right? Sex and cancer and all of these things. Who doesn't need a team to help with mental health care? Everybody does. Everybody can improve with mental health care, absolutely. And I always say everybody can get better at sex, right? Nobody's so good at sex that they can't get better. And when cancer is involved, sex lives change, and you got to work on the mindset around sex changing, because the dance may change, but don't stop dancing. The dance may change, but you should not stop dancing. And so what are ways that you can find people to help in these team members? So the Sexual Medicine Society of North America, SMSNA, is a wonderful organization. I know your last lecture from last week is very involved in the Sexual Medicine Society of North America. And if you are, you can certainly find a provider there. If you need a pelvic floor physical therapist, I know Fairfax has wonderful people, but you can go to these websites if you're out of town, if you're not from local, you can go to websites like pelvicguru.com and search your area and search kind of what you need, and they can find you, and you can look at profiles of different people. When it comes to mental health care, there are a number of ways you can have resources. It sounds like this group who's running this show has incredible resources, and I know I've spoken to their support group several times, and I'm always impressed by whatever Inova is putting out there. They are really the premier destination for all of this stuff, and it's really, really wonderful to see. If you aren't in town, and you can go to places like psychologytoday.com and search for therapists or sex therapists if it's interesting to you. There are organizations like ASECT, which is the American Association of Sexuality Educators, Counselors, and Therapists. And so that is a good way to find a provider in your area. And so again, there's a lot of biology in all of this. And when I think of these things, I really think about, where in your body is this all happening, right? I spend a lot of time thinking about different areas because while I am a genital doctor and I take care of genitals, I also have to understand and know about the brain. I have to understand the spine. I'm not that good at it, but I try. I try to learn as much as I can because it's really important actually for the stuff that I do. And so I try to break it down when I listen to people's stories and their cancer stories. Did you have surgery, right? Where did they operate on you? What nerves might have been affected during that operation? How are you experiencing sexual activity now compared to how you were before? What does sex look like now? What do you want it to look like? What are the goals, right? Can we achieve those goals? What goes into achieving those goals? How do you feel about all this? And if you have a partner, what does your partner think of all of this? And so it gets really complex. Like there's no way to do it in 10 minutes. It does get really complex, but we can make a lot of progress when you get to know someone and you can figure out what it is that they care about, what they want to do. And so again, the pelvis, there is so much biology in the pelvis. There's a bladder, a prostate, there's a penis, there is a rectum, there are small bowels that all live there. There's so much. And if you've had any type of cancer, and this goes for any gender, of course, but if you've had any type of cancer, it can affect your sexual health, right? The penis, as I said, is just a muscle, and that muscle and that penis needs arteries that fill the muscle with blood. And the nerves from the spine are what tell the penis to erect and orgasm and all of those things. And so hormones really matter. Testosterone levels matter for sexual health. Healthy nerves, healthy arteries, all of those things are important. And all our cancer treatments can affect those things. And all of our aging can affect those things as well. And so it is often inevitable that people's sexual health changes. But again, just because the dance may change doesn't mean you should stop dancing. And so again, if you think about it, right, the penis is a muscle, and the muscles that live in the pelvis, you've got lots of muscles in the pelvis that are responsible for things like orgasm, things like getting all of the urine out, things like if you have pelvic pain, these muscles can really be effective. If you have hip pain, right, you could have genital pain as well, or issues like that. And what's so fascinating about my work as a urologist is I take care of everybody. And it turns out that genitals all start from the same place. We all start with the same genitals. And again, depending when you're in the uterus, you either develop a penis or a vulva. But those body parts are exactly the same. They have the same nerves, they all, and they act the same way, which is kind of wild because no one really teaches us that. But really, the head of the penis and the head of the clitoris are exactly the same. The shaft of the penis, right, and the shaft of the clitoris, which is mostly internal, are exactly the same. Both the penis and the clitoris have legs. Okay, I bet you didn't know this. Many of you didn't know this. They have legs that split off and go to your butt bones. So if you're all sitting listening to me, and you go rock from side to side to side, you feel those little butt bones jut out, and everybody's genitals insert into those butt bones, whether you have a penis or a clitoris. And so this penis and clitoris, they're made of muscle. They're made of smooth muscle that expand and get bigger when they are relaxed or aroused, right? That's your erection. And everybody gets erections. We just talk about male erections and we don't talk about lady erections, but that's for Instagram, for me to rant on Instagram. But so it's really important because the biology matters here, right? For many people who have trouble with erectile function, let me turn that noise off for you. Let me just do 1 second here. So I gotta close my email really quick. Okay. And I'm going to stop share. Sorry, 1 second. And share again. All right, hopefully this is helpful because y'all are very quiet in the chat box, but we're going to keep going here. Give me a thumbs up in the chat box if this is going well. All right, here we go. Back to the pictures. So, can you hear me is the most important part. Someone put in the chat box, say, yes, I can hear you, doctor. All right, I got a thumbs up. I'm happy. Fabulous. You know, the Zoom is hard when you don't get much feedback from people. So again, we all start from the same place. And so if erections become a problem, And say you have, again, have to get to know, where do you want your erections to go? Who are you using these erections with? Is it by yourself? Is it a male partner? Is it a female partner? What kind of sex do you want to have? But it's really important, because if erections are a problem, can you have no sex? Is sex completely off the table? What does sex look like for you? And so that's funny. Somebody wrote something funny in the chat box. So what do you want sex to look like? And how does your partner experience pleasure? Because I think we're often not very much taught about how we experience pleasure. So we're even taught less about how our partners experience pleasure. But for most female, if there is a female partner involved, which is not always the case, most female partners do not get maximal pleasure from penetration. And things can happen to the female body that makes penetration painful. But much of the pleasure can happen externally, just like the penis is the source of orgasm for most men, the clitoris is the source of orgasm for most women. So oftentimes penetration is not needed for wonderful sexual pleasure. And I taught a lot of people today, actually, in my clinic, that did you know you do not need an erection to have an orgasm? The body, they're separate systems. You have separate operating systems. So your libido is different than your erection, which is different than your orgasm, which is different than your ejaculation. And nobody knows that. Everyone is just used to everything working all at the same time. So let's go over a couple things, because remember, y'all, I do 4 things. I do libido, arousal, orgasm, and pain. So let's briefly talk about each of them. So when it comes to libido, that's your desire, your interest in sex, how much you want sex. And I will tell you, there's a lot of biology involved in how much sex that you actually want. Now, there's a lot of psychosocial issues. If you are if you're feeling terrible about yourself, if you feel like, stressed all the time, if you're constantly worried about your performance issues, yeah, your body's going to create a lot of adrenaline, which is going to hurt your sexual function. And so that is biology. So stress is biology. We gotta remember that. But there's a lot of biology that goes into desire. And so things like dopamine, right? This is why vacation sex is so fun for people. This is why role play and different toys and newness and excitement, that's why it works, because dopamine works. Now, unfortunately, the kids are not having sex anymore because they're getting all their dopamine likes from Instagram. And so they just don't even learn how to talk to each other. So that's a whole other separate set of issues. But in addition to dopamine, a lot of hormones play a role in increasing dopamine and helping with desire and arousal. And so if cancer treatments have affected your hormone levels, no matter what gender you are, it can affect your sexual health. And again, when you understand your body and how it's working, you make good decisions for what kinds of things you want to try. Now, antidepressants, right, boosting serotonin can be so wonderful as part of your treatment modality to really help you with depression and anxiety. But medications can have side effects, and many antidepressants can decrease libido and delay orgasm. That's not to say everyone stop their antidepressants, y'all. Gosh, it's 2024. I don't know anyone who doesn't need antidepressants. It's really hard. We like, life is very hard. And so understanding what different side effects and which medications have side effects, and are there other medications that can be tried. And so when it comes to libido, it is very biopsychosocial, because of course, if you're not happy in your relationship, if you don't have a relationship and want one, if you are unhappy with what's going on in your life, it makes it very hard to have great sex. And so this is where, again, mental health care and education are so incredibly important, but there can be biological things that can help with libido as well. When we talk about arousal and orgasm, right, it is really, really interesting. It's really about nerves and blood flow. So understanding how erections work, how the nerves and the arteries and the muscles all work together, there is a lot of biology involved here. And if we talk about, this is an interesting one, I'm going to throw some interesting fun facts so for the next cocktail party you go to. So we all know there's a pay gap, right? Like women are paid much less than men. Like that's why I had to start my own practice, because I wanted to get paid the way all the men get paid. Women make much less than men do. Well, women actually orgasm less than men do. Did you know that? So if you ask anybody, any heterosexual man, at your last sexual encounter, did you have an orgasm? No shock to anybody. 95% of men say yes. Okay. If you ask a heterosexual woman, only about 65% say that yes. It gets a little better if it's a bisexual or homosexual person, the improvements in the orgasm ratio. And that has to do with education and knowledge of how the bodies work, right? So if you were to give every man in the world who entered a vagina, so every heterosexual man in the world, if you gave him a stopwatch, what's average time for a man to last? Does anyone want to be brave and go in the chat box? There's no judgment here. What is an average time that it takes around the world for a man to have an orgasm? We'll see if anyone's brave enough. It's okay if you're not brave enough. You can privately message me. I'm going to give it one more second. Okay, we got a guess of 8 minutes. Anyone else? 5 minutes? We got smart people on this call. All right, so we got 2 answers here. Ooh, I'm gay. Does it? Well, it does. It's true. This study was done in vagina owners, but I think the numbers, it needs to be studied. There's no question. So we'll talk about it. So the answer is about 5.5 minutes goes by, right? And it's very interesting because it's 7 minutes in the United States because, right, USA all the way. So this data is important because if you switch and you go back to heterosexual couples and you give the women the stopwatch, how much time goes by? Anyone want to guess? What's the average time for a woman to have an orgasm? No one wants to guess. 15 minutes, 25 minutes. Thank you for guessing, people. 1 hour. Fabulous answers. About 13.5 minutes, but 17% of people in this study never had an orgasm, never orgasmed. And as we know from biology, penetration is not the way most of these people even ever orgasm. So, right. So we just got the question there. So penetration was not the way to orgasm. And we know that. Now, this is very funny data, right? Science is silly because there weren't many high numbers here. So if you're in the Czech Republic, apparently you orgasm much faster than if you're in Hungary. So the next time you all go to Europe, you can test your own theories there. But why is this, right? Our genitals are exactly the same. And actually, if you let a woman or get herself to orgasm, it goes to 5.5 minutes. So there actually is no difference in how quickly someone can orgasm. It's just distraction can sometimes be an issue. And again, penovaginal intercourse is not the way that most women orgasm because their erectile tissue, it lives above it and more inside and somewhere else. And so orgasm, again, we see a lot of delayed orgasm. We see orgasmic pain. We see pelvic floor dysfunction. We see a lot of issues with having orgasms after, different kinds of cancer procedures, depending on how it affects your nerves. And so like anything, if you need a device that helps you, like I wear contact lenses or use a device to drive to work every day, sexual devices are awesome in 2024, y'all. This is no longer the seedy sex stores of yesteryear where you have to feel bad about it. You can go on Amazon and find really incredible devices that are of high quality and really help aid in solo orgasm and couples orgasm. It really, really is excellent. Now, pain is a big thing that we see, right? We see we see a lot of pain, and cancer treatments can really cause a lot of pain. And it really is important that you work with a team of people who understand this deeply. And we helped with a book, Facing Pelvic Pain. This was a lovely book out of Mass General that we helped with a couple chapters on. But again, it becomes really important to understand the nerves that are affected, the tissue that was affected, the surgeries, the radiation, the chemotherapy, the different kinds of treatments that you had, and also knowing that your cancer surgeon or your radiation doctor may not know everything about sexual health. And so it's really important to talk to them. So again, when it comes to the biology around erections, remember I said adrenaline is biology. So I always tell guys, if you're running from a tiger and you're in the jungle and you're running from a tiger, do you want to get an erection? No, right? Evolution says you will get eaten by the tiger. And so you have to understand that if you are stressed, if you have stress in your life, around sex, around cancer, around all those things, and you create this adrenaline, it does not help with your erectile function. And so it's really important to really work on that piece of this. But there is so much biology when it comes to erectile function. We really don't think about it anymore as, oh, it's all in your head. It's always either adrenaline mediated or a vascular problem or a surgical problem or a cancer problem. And so it really is important. And then as we get older, we deal with things like clogged pipes. So the arteries get clogged. And y'all, the arteries to the penis are tiny compared to the arteries to the heart. Penis arteries are 1 millimeter, right? The blood flow to the penis is that size. The blood flow to the heart is that size, 3 millimeters. So the penis arteries clog long before the heart arteries. And so I always say that what's good for your heart is good for your penis, because we know that erectile dysfunction is an early marker for cardiovascular disease. So yes, you may have erectile dysfunction because of your cancer treatment, but as we get older, the risk factors for erectile dysfunction go up and up and up. And so things like diabetes and cardiovascular disease and hypertension, all of that can really affect the health of the penis. And we know medications, can have side effects. And so if you have medications that affect hormones, if you have medications that affect blood pressure, those can have effect on your erections. And so we have a toolbox, like anything. We have a toolbox, and it's not a one size fits all. And that's why getting to know you and what kind of sex you want to have is really, really important, because not all gay men want to have the same kind of sex, and not all heterosexual couples want to have the same kind of sex. And so it is really important to understand, and it changes over the years, right? All sorts of different things change. And so you got to really figure out what's right for you in that toolbox. A couple of helpful tips. If you smoke, it's not good for your penis. You should try to quit smoking and really get any resources you can to help you. If you, we have data coming out that came out recently that shows exercise may be as good as Viagra. So can you imagine what exercise and Viagra do together? That's fabulous. So we do really recommend exercise. Diet, we have a Medscape video coming out in a couple weeks that there's a prostate cancer researcher at NYU, Dr. Stacy Loeb, who just published a whole series on plant-based eating and how it really improves erectile function in prostate cancer survivors. And so the data seems to indicate that plant-based diet of whatever you can do, that doesn't mean you have to give up all the meat, but can you start giving up more meat? And can you start including more vegetables and plant-based things into your diet? It may help with your penis. And so it is something to consider. Obviously, pills, many of you know how the pills work. There's 4 of them. There's Viagra, Cialis, Levitra, and Stendra, and they all work to relax the muscles of the penis to let more, her Loeb, L-O-E-B, Stacy Loeb. The video hasn't published yet, but the article should be out. Her name is Stacy Loeb, L-O-E-B, and it's really fascinating data. And so these drugs work to relax the muscles of the penis so that more blood flow goes in. If you've had certain surgical procedures, they may not work as well. Some people, they don't work, but they work in a lot of people. Now, when you relax muscles, you can have headaches, you can have facial flushing, stuffy nose, things like that. Now, these drugs are so cheap, y'all. You can get them cash price. You can get 90 Cialis for $8. You can use it either a GoodRx coupon for the cash price, or even Mark Cuban, the guy from Shark Tank, has an amazing cash price pharmacy. Your doctor sends a prescription and you get 90 Viagra Cialises for $8. You can't beat it. So we love pills as a way to help with erections. If you don't like medications or you want to try something with the medications, vacuum erection devices can be really, really helpful. They take a little tinkering and learning how to use them. We love the website, A Touchy Subject. It's this really fun Australian lady who teaches people all about vacuum pumps and can really do a lot of really, really good education. Now, I can't stress vibration and pleasure and joy enough. We love devices. There are all sorts of devices that can help with erection, that can help with orgasm, and can really make sex more interesting and more fun, right? Y'all don't go to the same restaurants that you went to when you were 19. Why are you having sex the same way? You got to spice it up a little bit. Now, there are inserts. This has been really challenging to get to our veteran. We usually often use this suppository muscle relaxer for our veteran patients, but we haven't been able to get it for about a year now. But this can be a helpful option for many patients. And many of you may have heard about injections, which sound crazy, but if you take a tiny needle and a liquid muscle relaxer and you put it directly into the penis, you can often get porn star level results. And who doesn't want to be a porn star? None of you need to be a porn star, by the way, but how else do porn stars keep their erections for 2 hours? Y'all, it's not magic. There is pharmacology involved, and these are things that don't cost very much money and can really help. If getting an erection is really a goal, these things can really, really help to give you a reliable erection. Now, we have a wonderful surgical procedure that is not for everybody, but is for many people and can lead to really wonderful, satisfying sex life, where we implant balloons inside the penis and we pump and fill it up with fluid to allow for a hard erection. Now, when we do these surgeries, you got to know what it is and you got to know what it isn't. So you have to work with a doctor who can really explain the pros and the cons and the risks and the benefits. And so it's not a perfect surgery, but it really does help with that functional erection. It shouldn't change your orgasm or your ejaculate if you can still do those things. And it really just replaces your erectile tubes. Now, many of you, if you drive to work, hear all sorts of things on the radio of come to this clinic and spend a lot of money and we will cure your penis problems. It's often when things sound too good to be true, they are often too good to be true. But there is emerging technology about something called shockwave therapy. Now, shockwave therapy is very exciting. We've used it since the 80s for kidney stones. It breaks up kidney stones. And it turns out that when you lower the intensity of the shock wave, you can cause sort of a reaction in the cell that can really help recruit stem cells, can help with nerve repair, can help with angiogenesis and bring in blood flow. So, of course, the Germans who invented it in the 1980s says, what happens to the penis? And the data does seem to show some improvement with erectile function. My slide didn't go through. I had some data to show you, but it does show for people with mild to moderate erectile function, it can really help. Now, the problem is many people try this when they have very advanced erectile dysfunction, so they don't notice much benefit. These therapies seem to be the best for the people with a little bit of ED. The pills work, but they don't want to take pills anymore, or they want to come down on their injection dose and just take pills. Now, there's also different technologies. There are machines that they say they are shockwave, but actually it's a radial wave device, and the physics are different, and it's not an actual shockwave. And so it is really, really important that you see a good person who knows what they're doing and who has the correct technology, and you also know what it is and what it isn't, and you are not promised perfection, because perfection often doesn't happen. Now, I'm happy to answer more questions as we go, sort of about other sexual health problems, in addition to things like we talked about libido, we talked a little bit about arousal, orgasm, and pain, but there's a lot of other things that can happen: penile curvature, ejaculatory issues, urinary incontinence, which is a really important topic as well. And so there's a lot here, a lot more that can be covered in just a 1 hour sort of lecture. And I certainly want to make sure that we spend time answering your questions and talking to you. A couple fun resources of things I've done over the years. And again, one is the Zero podcast, the Zero Cancer podcast. We did a nice episode a while ago. We also, and I'm happy to send these links. The Prostate Network, we did a nice a podcast episode. Again, I repeat a lot of the same things, and so you don't have to listen to all of them. I'll probably repeat myself. There's also a nice episode of the In Your Pants podcast, all about shockwave therapy and erectile dysfunction, where I really do talk about the data, what we know and what we don't know. As I said, I have a newsletter at rachelrubinmd.com. If you're interested in following along, we're doing some very cool things. My dream is to build the Center of Excellence for comprehensive, it's like a cancer center, but for sexual health. I want research. I want fellowship training. I want advocacy. I want to change the whole world, make it normal to talk about these things, but I want to do it at a very high, sophisticated level of science. And so, unfortunately, the NIH and university systems, sex doesn't sell. It doesn't get a lot of funding. It doesn't get a lot of care and research, but I know, and my patients know, that it matters deeply to them and their partners. And so anyway, I'm so grateful to be invited to do this. Thankful to Dr. Rosner, who just runs an amazing program at Inova, and for the Inova system, which really cares about their cancer survivors and does really, really, really great work. So thank you so much for having me. And let's get those questions going. I don't see enough of them in the chat box, so let's get some questions going.
Thanks, Rachel. So let's see if we have some questions.
I was so good that not a single person had a single question for me. I'll take it.
I see one question that I think is interesting. Somebody who has an implant.
Oh yeah, I can read it, or you can. Why don't you read it?
that?
You want me to read it?
can climax with oral sex but not intercourse. Can you comment on that? Is it due to
Yeah.
what
Yeah,
do you
so it's a great question. So there's a person who, a prostate cancer survivor, had radiation and 2 years of androgen deprivation therapy. So not only does radiation damage the muscles that surround the prostate, we just published a paper about how it does affect your ejaculatory functioning. And when you add ADT to the mix, people don't really seem bothered by those issues because their libidos are so low because their testosterone is really low. And so all of those things can affect nerves and sensation and also muscle health. And so it may be that you get more sensation from an oral sex stimulation as opposed to perhaps whatever else you're trying to penetrate. And so that's where I, again, really like to use devices. I really like to use what works for you because, again, you are able to orgasm, which is wonderful. And it just may not look exactly how it did when you were 19. And so we lean into the pleasure piece. We lean into what is working and how we can have as much fun as humanly possible. Now, there are different wearable devices that you can have that vibrate your perineum, which is, so your orgasm muscle lives behind your scrotum. And so they have devices that you can put on that stimulate that muscle while you're trying to penetrate. And so again, maybe it lowers the threshold or gives you more sensation while you're trying to do this activity. So I hope that's helpful. And again, I think that there can be workarounds just to remember to have fun and enjoy yourself. Someone's asked me in the chat box about Eroxon. I have heard of it. I haven't yet seen anybody who's used it. And as far as I can tell, I haven't seen if it's really available yet in the United States. If you know that, tell me, I'm interested. It seemed like from the studies, it seems almost like it's like a Bengay or something, almost like a warming mechanism. That's why it helps with erection. But I have not actually seen it in play with any of my patients. But I also saw the FDA approval that came out. So I'm very, very interested. Can you use the honey packs? I don't know what that means, and I want you to explain it to me because I want to learn more. Post radiation, I'm rarely able to ejaculate. So similar, we just published on this actually with our radiation oncologist at Georgetown, who does a lot of work in this area, and it is a problem. We know that that radiating the tissue can affect the bulbospongiosus muscle potentially, which is that muscle that allows for orgasm. So again, it's the question of if you add more stimulation, can you get that reflex to happen? So either strong vibration, right, or something to just see if it works. Now, I also think pelvic floor physical therapy is a really nice option because if you can retrain your muscles, sometimes we can get that orgasm reflex to come back. Now, here's a place where testosterone also may be worthwhile. Now, every individual has different risk factors, but we used to be very afraid of using testosterone in patients with prostate cancer. And the data and the pendulum has shifted a little bit. So sometimes there's more ability because you need testosterone for healthy muscles. And so sometimes with those androgen deprivation medicines, it can really, really affect the health of the penis tissue. Prostate surgery or radiation therapy can often cause shrinkage. Any thoughts, anything that can help? So we do know that sometimes prostate surgery can lead to some shortening of the penis. Here's where I love prehab and rehab. I love vacuum pumps for this patient population and stretching devices to really not just for erections, but for really stretching the tissue as much as possible to prevent any scar tissue. So I think those can really help. I think there's a great role here for daily Cialis, so a small microdosing of Cialis every day and some macro dosing of Cialis right before you do want an erection. I think those are good. In terms of the things that stimulate, there's all sorts of perineal stimulating devices. Some are attached to cock rings or constriction bands, and some aren't. And so there's all different kinds of wearables that are out there. And really, the sex tech industry has it's really beautiful. Actually, they do a lot of incredible sexual health devices that and they're looking at data, they're doing research. It really is beautiful to see how we're all working together. I have a lot of friends now who make these devices. There's a guy who owns a company where he's an engineer and used to work for Deloitte, and now he makes vibrators, and he's always listening and listening to us about what the needs are. He wants to help with complex issues and help using technology, which is so great. So I don't know much about what honey packs are and what's in them. You know, a lot of these things like gas station pills and Rhino and all these supplements that they're selling, it's really an unregulated market. And so I kind of say use caution. There may be elements of Viagra and Cialis in those medications and things like that. But again, anytime you're going to those types of things, oftentimes we have medications that might be a little safer and a little better, and we know what's in them. So I don't know specifically about that product.
Rachel,
Yeah,
Rachel,
please.
can you address there's a question, one of the question areas about addressing the fear around testosterone supplementation. And I think that's a great question because certainly I think for decades we thought that obviously testosterone or prostate cancer is very androgen sensitive. And I think now that there's some new data to suggest that testosterone after prostate cancer treatments is okay.
So what do you tell so Dr. Rosner, what do you tell your patients? And are you cautious or are you optimistic?
I'm optimistic. I sort of embrace it. I think that there can be a role for people who are doing well with their prostate cancer treatments, either radiation or surgery, and they have low testosterone. I think giving testosterone in the appropriate people is fine. And
Yeah, I'm so thrilled. I'm so thrilled to hear it. And it really is what the data shows. I just got back from a Harvard course on testosterone therapy taught by the guy who really did all of that groundbreaking work and bring that advocacy in place. And it's really a fascinating story. I have a blog post that I wrote about on my website that it really paints the story quite well of this idea that your prostate has so many receptors for testosterone and they get saturated. Like if you like once all of the receptors are full, any additional testosterone in your body doesn't change what happens to your prostate. And so if you have localized prostate cancer, it's not going to change whether you go higher or lower on your testosterone because those receptors are already full. It becomes when you have very bad prostate cancer or they really need to deprive the cells of testosterone that we start talking about castration and androgen deprivation and that sort of thing. And so for localized prostate cancer, there really is a safety and the data really does encourage the safety. And so I think it's really underused in many patients and it really is so fun. It's so fun to be me when I get to give the testosterone and the patients come back and they are just, oh, Dr. Rubin, I saw a guy today. He said, I have energy again. I'm just like, I feel like me. I just feel so good. And it's just like, it's so wonderful. It really is fabulous. So that's a great question. And I'm so glad that Dr. Rosner shared her thoughts as well. Woo, you all, I talk fast. What do we ask a provider about the low intensity shock wave device that they use? Storts was used in clinical trial, but how to avoid devices that won't work? Bruce, it's a really important question. And you have to find out what machine they have and what the technology is. And if they start getting sketchy about the answer, walk out and leave and don't go back. And so there are devices like called Gainswave devices, which are all radio wave devices. When you go to a machine or a place, it's like a mill where they're seeing tons of people and they're not experts in this, like they're a dermatologist doing, or not even a doctor, where they're not even a doctor doing erectile dysfunction. They often don't spend the money on the higher quality machines, which are the ones that have the data that work. And so it is important. So it's either electrohydraulic, electromagnetic, or a piezoelectric, I think it's called. So on my website as well, rachelrubinmd.com, there is another blog post all about shockwave where I talk about the different types of technology. So if you need a reference to just say like, what was the one she talked about? That's a good resource to kind of look at that. So you want to make sure that it's good technology. And there are a couple of machines out there and brands out there that do have the good technology. Why does the generic Viagra give you a headache? It's really interesting. The difference between generics and regulars, I will say I love generics because they are so cheap. And so you got to play around, because sometimes if Viagra gives you a headache, Cialis may not give you a headache. So if pills, they're muscle relaxers and they don't all work the same way exactly. So you could try a few different ones. And I'm sorry you're getting a headache. It is no fun to have a headache. Is your radiation effects solely about prostate cancer radiation? I had rectal cancer and managed to avoid surgery, but I did have chemo and radiation. So actually, that's why I tried to keep it as broad as possible, because radiation to the rectum absolutely could have the same effects as radiation to the prostate. They're so close together that my guess is that the radiation precision is still going to get your genitals in a way that you could have these effects. Now, nothing applies to everybody, but if you are noticing these effects, and certainly chemotherapy can have a way of really reducing your testosterone levels and really affect things as well. Nerve density and nerve sensation. There can be a lot of side effects to these medications. So again, they are inevitable, and they're important to help treat your cancer, but there are unintended consequences of these things. And so again, you have to show yourself some grace and love and mercy and say, listen, this is the new dance, but we got to keep dancing. We got to keep dancing. We got to talk about it. We got to really work to maximize the fun, because the whole point of cancer treatment is to keep you around longer, right? I'm going to die, y'all. I'm going to, but how am I going to live? What do I want my life to look like? What do I want? What impact do I want to make? What joy do I want to have? How do I want it to look? We have to take the bad and the frustrating and the unintended, and we have to make lemonade and make it fun and pleasurable. And sometimes you need a team to help you do that and to be cheerleaders along the way, which is why we're grateful for the Laurens of the world, because that's what she does all day, every day. And we're so grateful. What should y'all are asking great questions. We got them talking, Lauren. It's very exciting. Thank you for answering that. So what do you suggest pre-prostate removal should I do? I love conversations about these things before surgery. It's rare that we get to have them, to be honest. I think a prehab clinic is brilliant and wonderful. And I love being a part of someone's sort of, I like being there for people during the process, before, during, and after. And I like being a part of the team, because we really, we cry together. We celebrate together. We have that thing of knowing that I'm not there to talk necessarily about the cancer survival. I'm there to talk about the living part and what does that look like, and really help guide those questions. And so there's no perfect answer of what you should do before surgery, or how to maximize and be sure that you'll get the perfect outcome, because no one's going to be able to guarantee you a perfect outcome. And so the key is a good healthy penis before surgery can optimize ourselves for a healthy penis after surgery, but it's not perfect. And we got to be prepared for all things, and do our best to help you get the sex life that you want to maintain or regain. Someone has stage 4 and just gets shots. That may be androgen shot. I'm not sure if that's a question or a comment, but happy to answer a question if there is one. There are some of us who may have a genetic mutation driving prostate cancer. Is there any research into whether there is evidence of genetic mutations that may drive sexual malfunction? Oh, Peter, I love the question, and thank you for asking it. And I wish that we had precision genetics and precision treatments and diagnosis in sexual medicine the way that we do in cancer, because we have people who take medications and I'll give you a perfect example. There's one for boys, one for girls, birth control pills and finasteride. Okay, here's 2 medications that affect hormone levels: birth control pills and finasteride. Finasteride can shrink a prostate and can help with hair loss. Birth control pills, we know how those work. Both of them, in many people, have no side effects and do fine and do what they're supposed to do. But there's a subset of people in each of those who take each of those medicine who have devastating sexual side effects. Devastating. Right? But no one is studying it to the level that we're studying precision cancer genetics, and it needs to be studied. right? It needs to be studied. So there is not much out there. There's some things that people are dabbling with, but it's not as robust, Peter, as I would like to see. Can we get a copy of this slides, Ian? Hell yes, I'm happy to give you anything you want. For prostate cancer, erection treatment, anything with stem cells or nerve grafting. So there's a lot of excitement around stem cells. And the problem is the FDA really started cracking down on stem cell research, thank goodness, because people were doing some pretty wildly crazy things. And so we haven't really seen great data come out. There's some animal models being done, and there's interest in this for regenerative therapy, and there's a lot of people dabbling. Nothing's really prime time yet that I have seen. And I go to the conferences, I listen, I'm active on Twitter, people tell me things. And so I'm hopeful, but I haven't seen it yet. I haven't seen it yet. And the data on like platelet-rich plasma is so far not good. So it's being studied, and so far it has not really shown to be better than placebo. Now, again, shockwave for mild issues seems to like work a little bit, not a lot. It's not a panacea of perfection. And we don't really have perfect data on post-prostatectomy, because if it helps with blood flow, the problem is usually the nerves, not the blood flow. So it may not be sort of a magic cure-all, and it can be expensive. And so you really want to be careful if you have limited income or limited money, where your resources go. Oh, that was the injections for Eligard. And I will say, Henry, I'm giving you a giant hug, and because androgen deprivation is really, really tough, and it really is not fun. And I tell, you're my only patients who truly understand the plight of a menopausal woman, because castration is what happens to every woman over the age of 50, and it comes with hot flashes and night sweats, poor sleep, osteoporosis, changes in metabolic health, and it is really, really challenging on sexual function. And so we treat a lot of people with these conditions, and there are things to do, and sometimes there's only so much we can do, but your dignity and quality of life matter above all. And so you really get to have to make those decisions of what we can do to support you in your cancer journey. So that is a wonderful question that you asked there. And really all the support in the world and all of the hugs in the world. Anyone else? Is there recovery from using Eligard? It depends if it's lifelong therapy, if it's, there is data, once you stop these androgen deprivation therapy, it can take up to 2 years to kind of figure out what your testosterone is doing. And so there are non-hormonal agents that we can do to help with some of these things. There are many things that can be done. And if it matters to you, then it matters. And there's some things that we can look into. Was that helpful?
This has been incredible, Dr. Rubin. Thank you so much. We have one more question. Dr. Rosnar, I don't know if you want to jump in here as well, so feel free. There was one more question asking, how do orgasms occur with an erection?
So, it's really fascinating how little we know about orgasm. So this idea, they're separate operating systems. So the nerves to your erections live alongside your prostate and then go to the penis from behind the penis inside the body. And that's why we see a lot of erectile problems with prostate surgery, right? Because those nerves get affected and you can't see them. It's not so much that like, oh, here's that big chunky nerve that we see and that we spare it. Dr. Rosner has a very hard job because she cannot see the nerve. She can do her best to preserve the tissue that surrounds the prostate, but she cannot see the nerve so clearly because it's very, very small. And so that's the nerves to the erections. Now, the nerves to orgasm sort of come through the spine as well, but then they go sort of around your hips and sort of through that perineum, that muscle that lives behind your scrotum. And that's how we think that there's a reflex that happens that sort of triggers that orgasmic response. But it's pretty amazing, in my opinion, that anyone orgasms as they get older because people have all sorts of problems, right? They have spine issues and back issues and hip issues and all sorts of things that can happen. And so when people don't have orgasm problems, I'm actually surprised. I think it's absolutely an incredible biology that we don't fully understand, but you really do need a perfect brain to penis connection. And so many things can go wrong sort of with biology. How does age factor in terms of erectile dysfunction? Listen, 50% of 50-year-olds have erectile dysfunction. 80% of 80-year-olds have erectile dysfunction. So it is normal to have a worsening erectile function as you get older. And so again, if you have cancer treatment and you're older, you may have more trouble than someone maybe who is younger. But again, so age is a factor because remember, you need muscles, arteries, and nerves to have good erections. And anyone who's 80 or 90 does not have the same muscles, arteries, and nerves that they did when they were 22. And so sex is not magic, it's biology. And when you understand the biology, then you can understand sort of what is happening. You mentioned a device to improve orgasmic sensation. What was it again? So really anything that vibrates or feels pleasurable may be worthwhile to try and consider. And there are many websites and many devices, even on Amazon. There is a lovely, I like the website, it's called Promescent. The reason I like it is because they have devices for everybody and it gets you started. So you don't have to buy one from that website, but you can start looking at what the different types of technology are out there. They have a delay spray that we urologists like for people who would like to last longer, that we often use. And so that is just a place to get you started. I can't tell you what device you should get because everybody's bodies are different. And so unfortunately, sometimes you need to try a few things out and have a drawer. If you're in Virginia, many of you are in Virginia, there's a wonderful store called Lotus Blooms. I'll write it in the chat box. It's called Lotus Blooms. The people who work there are fabulously educated and really wonderful to work with. And so you can feel really comfortable talking about what's going on, and they can be an excellent part of your care team, actually. It's really cool to have partners in this space. I had surgery, radiation, and androgen deprivation therapy 6 years ago, and I have no erections. Is it too late? It is never too late to experience joy, intimacy, love, and pleasure, and you deserve all of those things. And so if that means erection to you, then there are tools that you can try and things that you can do to try to regain erectile function. But you are perfectly capable today of love, intimacy, connection, and good feelings. And so start there, and then go see a specialist who really understands sexual health, who can really help sort of bring things back to life, if you will. And you have options. I can't promise they will all work or any of them will work, but they're worth trying if it's important to you. And there are things that you definitely could try, and it's never too late. I talked to a veteran today who is 80 years old. I'll finish with this story. And he came in and he's talking to me. He mentioned something, and I said, the day you stop looking is the day you die. And his libido was as high as ever, and he was so super interested, and he was nervous about trying the injections, but we convinced him to do so. And I said to him, you got 20 years left. So we got to have much fun and pleasure in those 20 years. And he said, Dr. Rubin, can you promise me those 20 years? And I said, yes, I guarantee 20 years. And I wrote it on a prescription pad. And I said, I guarantee 20 more years of fun and pleasure in life. And he was very happy. So it was a very funny story. But there is no age with which this stuff stops being important to you. And if it matters to you, if it doesn't matter to you, then it is. No one died because they didn't have an orgasm. It has yet to be reported, right? So you do not have to have this in your life, but if you want it in your life, if it's important to you, then it should be important to your care team. And sometimes you have to expand your care team to make that happen. So thank you so much for having me. This has been just lovely.
Thanks, Rachel, so much.
My pleasure.
This was incredible. Thank you both so much, Dr. Rossner, Dr. Rubin, for being here. I mean, just absolute fabulous information. We're so grateful to you. To those that attended, thank you so much for being here with us. We're so grateful for you being here and allowing us to do this program with you. We will hopefully see you again on Tuesday, March 12th for our next session in the series.